video.
Both my audio and video are working fine.
So I'm in the live chat. You can ask me any questions, or please once confirm if both my audio and video are working fine.
So I'm in the live chat. You can ask me any questions, or please once confirm if both my audio and video are working fine. So I'm in the live chat. You can ask
So I just conducted one small quiz of these questions, which were recall questions of this INI-CET which happened in this November. So it is a part one.
small quiz of
So on
these
YouTube,
questions,
I'm taking this part one in which
which were
few of the
questions
questions
of
were
INI-CET
discussed,
which happened
and in the
this
part
November. So
two,
it
it
is
will
a
be
part
discussed on
one.
Unacademy. I will
So on
provide you
YouTube,
the
I'm
link
taking this
if
part
possible
one
in this
few of the
particular
questions,
YouTube comment section.
were discussed. And
Okay,
in the
so
part
myself,
two,
I'm
it will be discussed on
Dr.
Unacademy.
Maddineni
I will
Srinivas, your dermatology
provide you
educator.
the link
I have
if
done my
possible
MBBS
in
from
the
Siddhartha Medical
particular
College
YouTube
and
comment section.
diploma from JSS Mysore, and secondary
Okay.
DNB
So
in
myself, I'm
dermatology from
Dr.
Hindura
Maddineni
Hospital,
Srinivas, your
Delhi.
dermatology educator.
And this is my
I have done my
Unacademy profile.
MBBS
If
from
you're not
Siddhartha
yet
Medical
following
College
me, you
and
can follow me
diploma
to
from
get all the
JSS
latest
Mysore,
updates
and
of the
secondary
videos
DNB
whichever I
in
post.
dermatology
And this is the
from
part
Hindura
2
Hospital,
which I
Delhi.
was talking about,
And
in
this is
which
my
both
Unacademy
the
profile. If you're not yet
questions which were
following me,
asked
you
and
can follow
also
me to get
the
all the
possible
latest
future
updates of the
questions
videos
which
which
can
are
be
post.
asked will be
And this is
discussed.
the part 2
This
which I
is
was
going to
talking
be
about, in
tomorrow
which
at
both
10 o'clock. So here is
questions which
the
were asked and
time.
also the
So
possible future
to be able to
questions
watch
which can
that
be
particular
asked will be
session, which is the
discussed.
part 2, you should
This is going
download
to
this
be tomorrow
India's
at 10 o'clock.
number
So
one
here is
online
the
platform for
time.
learning. So
So
it is
to be
Unacademy.
able to watch that particular
So
session,
here
which
in
is the
this
part 2, you
particular
should
app, every day.
download this India's
So every day
number one online
there
platform
is
for learning.
there are classes going on. And also this with this app, so I hope the echo has now reduced. So Dr. Usha, I hope the echo is now reduced. Please give confirmation once whether the echo is reduced or not. Okay, thank you for the confirmation. So please download this app so that you will get access to these questions, 20 questions every day at 8 o'clock and at 9 o'clock. These questions from all the subjects are being like they are being taken like T20 match. So 20 questions in 20 minutes, 8 o'clock to 8:20 and 9 o'clock to 9:20, depending upon your target, whether it is NEET PG 2021 or 2022. And if you like, you can also take the plus subscription. The details of this I will brief you at the end of this particular session. So it will make the educator very much happy when we see these kind of testimonials from the students. So now yeah, so now please try to answer this question in the comment section. What do you feel is the answer? Okay, Dr. Usha says option C, that is Dapsone is the answer here. So does everyone agree with the answer? Okay. Dr. Sai Amarnath Reddy is also with the answer Dapsone. So please friends, everyone, whoever is watching this particular video, please do participate actively so that even if you make a mistake also, with that mistake you can remember it for longer duration. Okay. Dr. Aditya says it is B. Okay. Dr. Chandu says it is C. Okay. So majority are with the answer C. So we will go with the answer C only. So first, before you are able to tell what is the treatment of choice. Okay, what diagnosis were you thinking, Dr. Usha, Dr. Sayamanna, Dr. Chandu, and also Dr. Aditya? What diagnosis was in your mind? Very good, Dr. Usha. Dermatitis herpetiformis. So please remember, whenever these vesiculobullous disorders topic and sexually transmitted disease topic, these two are very very important, and in this particular INI-CET session many questions were asked on the sexually transmitted disease. So those questions we will discuss tomorrow as a 1 hour session. I will discuss about these sexually transmitted disease, and we will see it will be a quick revision of all these STDs basically in the tomorrow session. So today we will see the other questions which were asked. So among them, vesiculobullous disorders is a very very important topic which is being asked so much in all the recent MCQ based examinations. So first you should be in a position to understand what are these type of these lesions which can be seen in vesiculobullous disorders. Okay, so what are vesicles and bulla? These are basically fluid filled lesions. So you are able to see this particular lesions, both of them are fluid filled lesions. If the size of the lesion is less than 0.5 centimeters, we are going to call it as a vesicle, and if it is more than 0.5 centimeters, it is called as a bulla. So these both are primary lesions. So you should be in a position to understand what are primary lesions and what are secondary lesions in dermatology. Here these vesicles and bullae, these are fluid filled lesions and these are primary lesions. And these vesicles and bullae, they are going to rupture and leave what are called as secondary lesions. Amongst them is erosion, which is a raw surface which is seen present over the skin because of the deroofing of these vesicles and bulla. So this will be up to the level of the epidermis, whereas crust, whenever this vesicle ruptures and there is erosion formed, so these whatever blood, serum, pus, whatever is present over this erosion, whenever it gets dried up, these dried up exudates, they are called as crust. So these are the primary and secondary lesions. And vesiculobullous disorders, these are subdivided into three main categories. Okay, the number one type are immunobullous disorders. Why they are called so? Because there is some component of antibodies and antigen reaction. So that there are antibodies produced, and these are going to act against the antigens which are present uh, in the skin, whatever it may be, various components against which antibodies are present, depending upon which we have again subclassified these immunobullous disorders into intraepidermal and subepidermal bullous disorders. Okay, so that is one classification, and in the other there are mechanobullous disorders. So these are genetic conditions. Basically these are epidermolysis bullosa, group of disorders which are again categorized into three types: epidermolysis bullosa simplex, junctional, and dystrophica. Okay, based upon the protein which is defective genetically, these epidermolysis bullosa disorders are again subclassified into three types. Okay, simplex, junctional, and dystrophica. And inherited acantholytic disorders, these are again genetic conditions, but here there is going to be a calcium ATPase defect, based upon which we are having two important diseases. They are Haley disease and Darier's disease. So here our focus is on these immunobullous disorders, which are again subdivided into whether the level of the split. So whenever the fluid filled lesions are there, so there has to be a level of split. So if at all a split is in the epidermis, they are called as intraepidermal, and the important examples are pemphigus group of disorders, mainly pemphigus vulgaris and pemphigus foliaceus. So these are the intraepidermal blistering disorders. Okay, coming to the subepidermal blistering disorders or intradermal blistering disorders, there are two important examples which you should know. One is bullous pemphigoid and the other one is dermatitis herpetiformis, and there are various others, like for example pemphigoid gestationalis and epidermolysis bullosa acquisita. So this is epidermolysis bullosa acquisita. Okay, here there will be antibodies against collagen 7. So it is different from epidermolysis bullosa simplex, junctional, and dystrophica. All those three were genetic conditions where this is a immunobullous disease. Okay, This is also a very important point. And the other examples are linear IgA bullous dermatosis. So these are other subepidermal bullous disorders. So what is the basic difference between these intraepidermal blistering disorders and subepidermal blistering disorders? You all must be in a position to understand this and know this. So this is a pictographic representation of epidermis and its layers, in which we can see topmost layer is stratum corneum, followed by stratum granulosum, followed by stratum spinosum, and finally stratum basale. Stratum basale is also called as stratum germinativum. Okay, so these epidermal cells, these are keratinocytes. Please remember, the principal cells of epidermis are keratinocytes. These are going to form 85 to 90% of the entire cell population of the epidermis. Okay, please remember this point. And you are able to see these green bridges which are present in between these keratinocytes. These are intraepidermal intercellular keratinocyte bridges, and these are nothing but the desmosomes. So desmosomes are going to help in connecting the keratinocytes with the adjacent keratinocytes in the epidermis. Whereas one small change, so all the keratinocytes in the epidermis are connected by desmosomes, but the bottommost cells, that is stratum basal cells, they are going to get connected with the underlying basement membrane zone, are also called as dermoepidermal junction, with the help of not desmosomes but hemidesmosomes. Okay, so why are we telling all these things? So in the epidermis, we have seen keratinocytes are attached with the help of desmosomes. So in these immunobullous disorders, there will be antibodies produced against the protein components of these desmosomes, because of which there will be loss of attachment between the keratinocytes. So this is a keratinocyte, this is a keratinocyte, and these green structures, these are the desmosomes. But there are antibodies produced in these immunobullous disorders, because of which there will be destruction of the desmosomes, and ultimately these keratinocytes, which were having this polygonal shape, this pointed shape, they are going to become round in their cell structure, because whichever is a circular shape, whichever occupies a circular shape, it is going to have the least amount of surface tension. So these cells take up the shape of circular cells, and these are called as acantholytic cells. Acantholytic cells. And please remember, acantha, wherever is there, acantha simply means spine, or you can say pointed. So these desmosomes are present in basically all the layers of epidermis, but they are present in maximum concentration in stratum spinosum. So we have given this loss of coherence between these keratinocytes the name acantholysis. Okay, so one more point which you should know is, if there is thickening or increased in the number of layers of the stratum spinosum in the epidermis, we will call it acanthosis. Again, the word acantha is common here, but we have added a suffix which is osis, which simply means that the stratum spinosum layer has thickened. Okay, so these are two basic things which you should know: acanthosis and acantholysis. So acantholysis is the separation of these keratinocytes in the epidermis. So obviously the immunobullous disorders which we talked, in these two types, intraepidermal blistering disorders are the one in which acantholytic cells will be positive, whereas in the subepidermal blistering disorders, acantholytic cells will be absent. Why? Because in the dermis, so these are subepidermal blistering disorders, that is, the level of split is below the epidermis, acantholytic cells will be absent in all the subepidermal blistering disorders. This is a very, very important point. And depending upon the mechanism by which the separation of these keratinocytes happens, we have primary and secondary acantholysis. So if acantholysis is secondary to alteration or damage to the keratinocytes, then we are going to call it a secondary acantholysis. And you should just remember that all the viral infections of the skin, herpes simplex, herpes zoster, and for that matter even verruca vulgaris, that is the common warts. So all these viral infections, they can show the secondary acantholysis because of the damage to the keratinocytes. Okay, otherwise here you can see pemphigus Haley disease, Haley disease, Darius disease, and bullous symptomatic, these bacterial infections. So all of these are going to show primary acantholysis. So now coming to this particular dermatitis herpetiformis, which was the answer here, which was the diagnosis here. This dermatitis herpetiformis has another name called Doering-Brock's disease, and we have seen that these are immunobullous disorders. So there should be some target protein which is going to act as antigen against which antibodies are produced. And please remember the target protein in dermatitis herpetiformis is transglutaminase 3. Okay, and there is one very important systemic association which can be seen with dermatitis herpetiformis. It is celiac disease, or also called as gluten sensitive enteropathy. So both these conditions are very much interrelated, and I will tell you what is the importance of this gluten sensitive enteropathy during the management part, and some memory based questions. HLA DQ2, DQ8 and B8. Please remember this B8, it was in fact asked in the JIPMER exam in the past. So this could be again repeated in the INI-CET, or for that matter even in NEET exam also. So what is the basic pathogenesis happening in this dermatitis herpetiformis? So this is a subepidermal blistering disorder. Here the gluten whichever is taken up in the diet, whichever enters through the diet, there will be antibodies produced against this, which are IgA type of antibodies. Okay, so when they reach the blood vessels, and from there when they reach the skin surface, so these IgA antibodies which are against this mucosa of the GI system, they are going to cross react with the transglutaminase which is present in the epidermis, in the skin. So because of which there will be development of the split at the subepidermal level, and that too specifically these particular antibodies, they love to get accumulated in these structures. These are called as dermal papillae. So please remember, I hope all of you know this concept. So if this is the epidermis and if this is the dermis, the projections of the epidermis into the dermis, these are called as reter edges, whereas the projections of the dermis into the epidermis, these are called as a dermal papilla. So here these structures are the ones in which the antibody and antigen reaction is happening, and there is a split. So this is a papillary tip. These papillary tips are going to have certain cells. Okay, so we will see what are those cells. So please remember this particular dermatitis herpetiformis, in this we are going to have the anti-endomysial antibodies. So these are going to act against epidermal transglutaminase, and because of this particular antigen antibody reaction, there is going to be interleukin 8 production, and this interleukin 8, it is a strong chemotactic factor, for neutrophils. Okay, so we have seen that blisters are seen. Yes, so blisters are seen in both bullous pemphigoid, dermatitis herpetiformis, pemphigoid gestationalis. But in bullous pemphigoid and the pemphigoid gestationalis, in that there will be antigen antibody reaction, but there will not be interleukin 8 production. Instead, there will be only complement system activation, because of which there will be excessive eosinophilic infiltration into the blister cavity. Okay, so but here in dermatitis herpetiformis, because interleukin 8 is produced, so this could be a potential MCQ of the future. Interleukin 8 is present in higher levels in the blister cavity, because of which neutrophils will be attracted and they are going to accumulate more when compared to the eosinophils. And this is the reason why we are going to have this micro abscess of the neutrophils in the dermal papilla. Okay, so with that, I just want you to introduce to one more concept which is famous in dermatopathology, and they are called as micro abscess. So like, why should only pathology people feel aloof when surgery people see so many abscesses? So because of that, even pathology people, they wanted to make things complicated and they named the collection of the cells in the skin. So in the skin, the inflammatory conditions like psoriasis, dermatitis, herpetiformis, these can present in the histopathology, in the dermatopathology, basically with collection of cells. So in the psoriasis, there is going to be collection of the same neutrophils, but the level is going to be in the epidermis, and depending upon the exact location of this neutrophilic uh, uh, clumping, they are have two names which are given to the psoriasis microabscess. They are Munro's microabscess and spongiform pustules of Kogut. So the level is stratum corneum and stratum spinosum respectively, where the cells are neutrophils. So neutrophils, when they are present in the stratum corneum, they are given a name Munro's microabscess, and when neutrophils are present in the stratum spinosum, they are called spongiform pustules of Kogut. So both these are basically psoriasis only, which is a papillosquamous disorder. So we will discuss it in a later like TND session I am planning. So in that sessions we'll see these particular individual diseases in detail. Okay, so here we are concerned more with dermatitis herpetiformis, where we have already seen the antigen antibody reaction is happening at the dermal papilla. So neutrophils will also get attracted here, and these are called as papillary tip microabscesses. Okay, these are called papillary tip microabscesses. So this is how the papillary abscess will be there here. So this is the epidermis, this is the epidermis which you are able to see, and this is the dermis. Okay, so there will be neutrophilic infiltration in the papilla, So these are the papilla, and here you are able to see this neutrophilic infiltration, which is papillary abscess. So this is another picture. This is the epidermis, and this is the dermis, and these are the papilla. These are the papilla, and these are the collection of the neutrophils. So this is the direct immunofluorescence image, which is showing IgA deposits in the papillary dermis in a granular pattern. This question was asked so many times. So please remember, granular pattern of deposition of IgA is seen in vesiculobullous disorder, and it is dermatitis herpetiformis. So here you are able to see these granular type. So granular. So dot dot. It is in a dot dot fashion, in a as if someone has poured some grains. So it is described as granular pattern. And if at all the question here asked what is the treatment of choice, and in the options if gluten free diet was there, then it would have been the best answer. Why? Because these dermatitis herpetiformis patients, they are going to be associated and they are going to be having this celiac disease, which is gluten sensitive enteropathy. So avoiding gluten in the diet is the treatment of choice. Otherwise, if drug of choice is asked, then the answer is dapsone. Okay, so dapsone is basically used in neutrophilic, wherever neutrophilic infiltration is going to be there. In those conditions, dapsone is the drug of choice. Why? Because this will reduce the neutrophilic infiltration. And this is a miracle drug for dermatitis herpetiformis, you can say. Why? Because there is one more question related to this dapsone. Please remember, it is not only used for the treatment of dermatitis herpetiformis, even it is used in some cases to diagnose this dermatitis herpetiformis. Like for example, I'll just tell you a quick scenario, clinical scenario. For example, in a PHC area, if a patient comes complaining of intense itching over the body, and there is only itching and some excoriations are present over the body. So what is the differential which you should think is? The first one is of course scabies, which is very frequently seen in the community. So the, for example, in the PHC, the treating doctor has treated for scabies, but again and again the patient is coming with the complaints being persistent. So what we can do, what this particular doctor can do, they can give dapsone as a not only therapeutic but a diagnostic purpose. So because this if at all the patient has dermatitis herpetiformis, clinically how it is going to manifest is there will be papulovesicles and the extensors, that is knees, lumbar areas. So all these areas, elbows, all these areas, papulovesicles will be there, papules and vesicles, and crusting will be there mainly. Vesicles will not be intact, they all will be ruptured, and excoriations only can be seen. So if at all that this kind of patient comes, then what we can do is we can give a therapeutic dose of dapsone, and within 2 days there will be a relief from the itching. So intense itching will be there in dermatitis herpetiformis, which is going to be completely reduced after this dapsone administration. So we can even diagnose the dermatitis herpetiformis with the help of dapsone. That is the reason why it is also used for diagnostic purpose also. This was a previous MCQ, you should know this. And in the case of gluten-free diet, please remember not all the food has gluten in it. So these mnemonic, you should all remember: barley, rye, oats and wheat. So these are the four food varieties which are to be completely avoided by the patients of dermatitis herpetiformis. So now what the patient can take? The patient can take rice and maize. Okay, so there is no problem. So when if at all this dermatitis herpetiformis condition occurs in North Indian, so there will be a very big problem for them. Why? Because they have to avoid taking wheat, which is the staple food, you can say, in the north. So in the South India, the people can, however, carry on with their day-to-day work, because it is rice which is usually used in this South India. So okay, now please try to answer this particular question in the chat section. So I have already told the answer while I was explaining dermatitis herpetiformis. So it was a JIPMAR question also. Okay, Dr. Usha says answer is A. Yes, so this, you are right, Dr. Usha. The answer is transglutaminase 3. Okay, please remember this was the past JIPMAR question. So you all should know about this. So now please try to answer this question in the chat section. Patient came with grouped vesicles periorally. What will be the Tzanck smear findings? Yes, Dr. Santosh, you are absolutely right. Okay, correct. So these kind of grouped vesicles are present periorally. This was the question which was asked, and this is a multiple answer question. So more than one answer can be there. So please try to tell me what will be the answer here. Okay, Dr. Usha says it is A and B. Okay. So everyone agrees with the answer. It is Tzanck cells and multinucleate giant cells. So please everyone try to actively participate in the quiz, friends. So yes, when we see these kind of lesions in the exam, So what we should think about is grouping and vesicles which are seen periorally, and in case if it is clinical type of question, there may be some mention of uh, history of recurrence can be given. So along with that, there can be some history of a prodromal of a fever was there, after which these vesicles develop. So this can these details can be given if it is a clinical based question, but since it is an image based question which they have given, so the diagnosis here becomes very much uh, easily understood. It is herpes. Okay, please remember herpes labialis. This is the viral infection which is going to present as grouped vesicles. Okay, grouping and presence of vesicles, these two are very characteristic of herpes. And some more characteristic points are there will be a history of recurrences, and in the clinical scenario they can mention that fever was there as a prodrome, after which the patient developed these vesicles. Okay, this could be the potential points, add-on points which can be given in the clinical type of question. So in the dermatitis herpetiformis, while I was explaining, I told that in viral infections we can see acantholysis, secondary acantholysis. And acantholytic cells are nothing but they are the keratinocytes, and they are called as Tzanck cells. Okay, so Tzanck cells, acantholytic cells, and keratinocytes, all of them are one and the same. Okay, and in herpes we are going to also see multinucleate germ cells. So we will see what are this, and first of all we will see what is the procedure of Tzanck smear. So we will select one of this vesicle, and we will take a scalpel and we will remove the roof of this vesicle. So we will remove the roof of this vesicle. So for example, this is a vesicle, we will take a blade and we will remove the roof of this vesicle. So the roof is removed. So now this is the base of this vesicle, from where we are going to take, we are going to scrape the base will be scraped with help of a blunt end of the scalpel. So don't worry, we will use blunt end of the scalpel. We will scrape the base and we will apply that whatever we have taken from the base onto a glass slide. So these procedures also could be asked in a sequence based question to arrange in a proper sequence. Okay, so we will apply this on the glass slide, and we will put Giemsa stain on that, and we will wait for 15 minutes. Okay, after 15 minutes in herpes, what we can see is these kind of round cells which are going to have prominent nucleus with a perinuclear halo. So these are called as acantholytic cells or Tzanck cells. Okay, so these are basically keratinocytes. These are basically our keratinocytes. Okay, which have lost their connection, intercellular connections. Yes, Dr. Usha, painful lesions was mentioned. So these vesicles, they are going to be painful. So painful. These herpetic lesions are going to be painful. So that is a positive history which is pointing towards a herpes infection. Very good. So that is a actually you can say that add-on point given in the question. So not only acantholytic cells or Tzanck cells, in these herpes infections, we are also going to see what are called as multinucleate germ cells. So here in the picture, these are the multinucleate germ cells where these cells are going to clump together, and they are basically there will be a rupture of the keratinocytes because of the ballooning degeneration. There is going to be what is called as ballooning degeneration of the keratinocytes, because of which the uh, different adjacent cells, they are going to rupture, and they are going to form a single mass of cell with multiple nuclei, and these cells, they are given a name, they are called as multinucleate germ cells. Okay, so these are characteristic of herpes infection, so please remember this point. So these are some of the other pictures of multinucleate giant cells. where you are able to see a single cell with multiple nuclei which are present inside the single cell. So we'll see few points about the other options. So these were told by the students that these options were given. So I am not sure. So please tell me whether these options were there. Taunton, Gent cells, and uh, were these given in the options? Yes, it's not molding. It is morning edge cells. Okay, you are right. So these particular acantholytic cells, these are also called as morning edge cells. Okay, it's not molding, morning edge cells. Okay, no problem, it's okay. So just this could be a potential MCQ of the future. Taunton germ cells, these are this will be again dealt with in pathology. There is no problem at all. So these are seen in xanthoma and juvenile xanthogranuloma. So these you should know that much, it will be sufficient. So these are basically having foamy cytoplasm at the periphery of the cell outside the nucleus. Okay, so these are Taunton germ cells seen in xanthoma and xanthogranuloma. That much if you know, that will be enough. And LE cell, this is a very important cell. You should know, lupus erythematosus cell. It is seen in systemic lupus erythematosus. Okay, this must be known. And these LE cells, they are an end result of either phagocytosis of the nuclear material. So in this systemic lupus erythematosus, there is going to be systemic auto antibodies against the cellular components. So the nuclear material is going to be phagocytosed by the neutrophils. So these LE cells, these are basically the neutrophils. Okay, this point all of you must remember. And apart from that, there is not much of this thing. Yes, very good, Dr. Usha, you are right. Okay, now please try to answer this question. Which of the following is correct about these particular lesions which you are able to see here? So among the four options, what do you think the answer is? Okay, Dr. Usha says central umbilication. So any other answer which anyone wants to give? Yes, Dr. Usha, your answer is correct. Molluscum. Very good. So the question says which of the following is correct among the statements about the image which is shown in the picture. So few students told that the image was not so clear. Okay, so Ajay Modi says option C is the answer. Okay, I will tell you what is the answer. So here if you examine this picture, this is very clear picture. So few students told me that in the exam the image was not so much clear. So here in the image you are able to see that these are raised lesion with a central depression. So these are called as pearly white. These are characteristically described as pearly white papules. So these are looking like pearls, pearly white papules with central umbilication. Central umbilication. So these are molluscum contagiosum lesions. These are molluscum contagiosum lesions. So Dr. Ajay told it is C. So please remember the gram negative cocci are seen, for example, if this question was asked, I think in pathology there was one question where they have given you gram negative diplococci are seen in which disease. I think you are confusing it with that disease, Dr. Ajay. So that was another question. It was related to patho, and I think the answer there will be Neisseria gonorrhea. And please remember, Neisseria gonorrhea, it is going to manifest in dermatology in sexually transmitted diseases in particular as urethral discharge. Urethral discharge, and that too when compared to chlamydial that is non-gonococcal urethritis, this Neisseria gonorrhea causing urethral discharge is going to be profuse and purulent. So frank pus discharge can be there in this. So it is not the case here. And Tzanck smear is not the investigation of choice in this condition. And Punt cells, they are not seen in Molluscum contagiosum. Punt cells. IBQ, image based question. Acha, okay, it was an STD case with image based question. Okay, we'll discuss that in the tomorrow session. So I have the question prepared. Okay, we'll discuss that in the tomorrow session. So Punt cells, these are seen in granuloma inguinal, that is donovanosis. So I will tell few points about this Punt cells. So this could be, so in AIMS, please remember the options could be the next questions, full-fledged questions in these particular AIMS or PJ or JIPMER, these exams. So basically this is the INI-CET combination. So this could be a potential future MCQ. So these Punt cells or green blood cells. Okay, please remember the name is Pund and green blood cells. These are seen in granuloma inguinal. So this is the picture of the Pund cells, and these are basically large mononuclear cells. The nucleus of the cell is eccentrically placed. So here this is the nucleus which is eccentrically placed, and there are less than 20 intracytoplasmic vacuoles containing donovan bodies, either in young non-capsulated or mature capsulated forms. So all these are the donovan bodies. Okay, so donovan bodies which are present in the mononuclear cells with the eccentric nucleus. This description, it is given a name. These are called as green blood and Punt cells. So these are seen in granuloma inguinal, which is also called as donovanosis. So please remember, this is a very big confusion for most of the students. Donovan bodies are not seen in Leishmania donovani. So many students make this mistake. Leishmania donovani is not the one in which donovan bodies are seen, but it is donovanosis. Donovanosis or granuloma inguinal. Okay, so please remember this one. And few points about Molluscum contagiosum. Few points about this Molluscum contagiosum. It is caused by a pox virus, which is a DNA virus. So there will be intracytoplasmic inclusion bodies. From histopathology point of view, intracytoplasmic inclusion bodies will be seen. Otherwise, in the clinical features, we are going to have completely asymptomatic pearly white papules with central umbilication. So we have already seen that there will not be any itching in the patients. So this with the help of this small mnemonic, you can say a trick. You can remember what are all the manifestations of Molluscum contagiosum. Pearly white dome-shaped umbilicated papule. So this is the classical description of the lesion. And one more thing you should remember is pseudo-Kobner's phenomenon is positive in this condition. Okay, pseudo-Kobner's because the lesions are going to be produced. New lesions are going to be produced because of the autoinoculation. So here you can see that if at all the patient scratches this lesion, then these viral particles will be present inside this depression as a cheesy material, and these will spread to the new areas and new lesions will develop. So because of the virus being auto-inoculated into the skin, new lesions are being formed, and it is called as pseudo-Kobner's phenomenon. And if we do histopathology, we can see Henderson-Patterson bodies. Okay. In the treatment part, it is mainly the curettage, that is will just scrape these lesions, because of which the viral particles will be completely removed. That will be the treatment which is used in the physical means. Whereas other topical ones are imiquimod, trichloroacetic acid and potassium hydroxide. So now please try to answer this particular question in the poll. Yes, Dr. Usha, you are right. So groove sign of green blood, it is seen in lymphogranuloma venereum. Okay, please remember this. So these green blood and pond cells are seen in donovanosis, whereas groove sign of green blood is seen in LGV. Okay, so these two are different conditions, and please make a note of this. This could be a potential MCQ of the future. That is the reason why it is important. Okay, I hope it is clear, Dr. Usha. Yes, Aditya says it is annular. Okay, anyone? Dr. Usha says it is a very good. So Aditya and Usha, both of you are absolutely right. So how, if this kind of image based questions will be asked, so you should be in a position to understand by looking at the image what is the type of lesion. So this is a very basic question, you can say. They all that they are asking is based upon this morphology, what is the type of the lesion. So here what is the characteristic of this lesion which you are able to see? So the central part and the peripheral part. So there are two parts in this particular lesion which you are able to see, and the peripheral, this is the periphery of this lesion, and this is the central part of the lesion. And if you observe the central part and the normal skin, what you can observe is both of them are same, that is the central part is completely normal, that is central part is spared or it is completely clear of any disease. So this is what we can infer from here. And the periphery, what is it showing? It is showing a redness or erythema, and if the image was very clear, then you can also appreciate scaling also. So periphery is showing erythema and scaling, whereas central part is showing clearing or it is spared completely. And this is a classical description which is used, and it is called as annular lesion. So please remember, whenever you get this word annular lesion, it simply means that central area is clear or it is spared from the disease, whereas periphery is showing activity, periphery is showing erythema and scaling, which simply means that the disease is active at the periphery. Okay, and not only annular lesion will be single, these annular lesions then they can coalesce and they can form. For example, here there was an annular lesion, and here there is another annular lesion, here another. So all these lesions, they can they can converge and they can become of this kind of lesion. So you can call these lesions as morphology of polycyclic type of lesions. So even these kind of lesions can be seen at places, but it is annular lesions which after coalescing form these kind of lesions. So these are also described as annular irrespective of the uh, bizarre shapes which is it is having. Okay, so these are also again annular lesions, and this particular lesion which you are able to see here, this is a case of eczema. So how we can say it is a case of eczema? You are able to see some shininess. This shininess is because of the oozing, and you are able to see some redness which is there, and you are also able to see some form of edema is there. So all these features are classical of eczema. Okay, so this is a picture of eczema, and if you look, the entire lesion is having only one type of morphology, and it is showing all these changes of eczematous changes. These type of lesions, they are given a name called as, because they are looking like a disc, like round disc they are appearing, so that is the reason why they are called discoid. So whenever there is a word oid, what does this mean? Oid means, it simply means that it is looking like, okay, it is looking like a disc, so it is called discoid lesion. And this particular discoid, it is also having one more name, it is called nummular. Nummular and discoid are both one and the same. Okay. Yes, this is discoid because it is disc-like, and the other name for discoid is nummular. Okay. So few points about this discoid or nummular eczema. So this is another image which you are able to see. This is also a discoid or nummular eczema, and these lesions are classically seen in the acral areas of middle-aged men. Okay, middle-aged men are the most frequently observed candidates who have this kind of discoid or nummular eczema, and this particular lesions, they are also given one more name called coin shaped blocks. Okay, so because these lesions are looking as if someone has put a coin, or if you anyone has put a coin over the skin, so how the lesion will appear, so similar shape and size will be there of these lesions. So these are called as coin shaped blocks, and because this is eczema, so obviously there is going to be itching which is going to be present, and the most common site are acral parts, and among the acral parts also most common sites are lower legs. Okay, so now please try to answer this particular question in the poll. Yes, so discoid lesions in SL, you are right, and in fact there is one form of lupus erythematosus called as discoid lupus erythematosus. So in this condition also we will see again the discoid type of lesions. Very good, Dr. Ijaj, you are right. So discoid lesions will be seen in SLE, and also there is a, a particular type of lupus erythematosus where only skin involvement will be there. It is called DLE. Okay, solid. So please read the question very carefully. So please read the question very carefully. Okay. So there is a catch in this question, so that is the reason why I have put it as a future INI-CET exam question, so that you should be in a position to catch this one very important word which you are missing. So I hope you have understood what is that small catch in this question. So the catch is this point: solitary. Okay, the question says solitary erythematous oval lesion with central clearing giving a target appearance is seen in which condition? So this is a future question, and the answer is not erythema multiforme as thought by most of you. The answer is erythema migrans. So did anyone answer erythema migrans? No. So no, Dr. Usha, it is not erythema annular. The answer is erythema migrans. And I will show you how a target lesion, typical target lesion looks like. So a typical target lesion is going to have three zones. Okay, three zones will be there: a central dusky zone, central, this is a we'll call it as a number one, and number two zone, it is pale where there will be edema, and finally a periphery which is going to be again erythematous. So now you might get a doubt, so what is the difference between this target lesion and annular lesion? So please remember, in annular lesion this peripheral erythema was there and this central clearing was there, but the most central part was not erythematous in the case of annular lesion. Okay, annular lesion lacks central erythema. So this is a very important point which will help you to differentiate between target and annular lesion. So this is the typical target lesion, and one more point which all of you should know is target lesions are classical special lesions which will be seen in erythema multiforme. So most of you have answered it as erythema multiforme in the this question, but please remember, in erythema multiforme target lesions will be multiple. Okay, so you can see it is going to be the extremities where the target lesions are seen more concentrated, and they are going to be multiple target lesions which will be seen. But in the question which I have asked, I have given that solitary erythematous ovulation is present. So the answer is erythema migrans. So what is this erythema migrans? It is also the full form, the full name of that condition is erythema chronicum migrans, also called as Lyme's disease. So I hope now you know what is a causative agent and what is this particular heart tick. So this is the exodus tick which will have in the gut of it Borrelia burgdorferi. And this particular tick, whenever it bites on the skin, this is the head will be inside the skin, okay, head will completely pierce inside the skin, and it is going to cause the introduction of this organisms, bacteria Borrelia burgdorferi, into the skin, because of which there will be a single target lesion which is formed only at the site of the tick bite, and this is having the classical central erythematous zone, middle pale zone, and a peripheral erythematous zone. So 1, 2, 3 zones are there. But unlike erythema multiforme, here in erythema chronicum migrans, we are going to have only one target lesion. So this is also a target lesion, but it is only one target lesion. So it is the case of erythema chronicum migrans. No, erythema multiforme is not seen in Lyme's disease, Dr. Ijaj. It is Lyme's disease, also called as erythema chronicum migrans. Okay, so I hope it is clear. Erythema multiforme is a different condition from erythema chronicum migrans. Erythema multiforme, it is usually seen, it is the most common cause for this condition is idiopathic. That is mostly the reason for the development of these target lesions is not known, but if at all infectious agent is present, then it is herpes, which is the most common infectious agent causing the development of this erythema multiforme. Otherwise, there are certain drugs, there are certain connective tissue disorders, and there are certain malignancies which are going to cause erythema multiforme. Okay, so in the infections, please remember herpes is the one which is going to cause erythema multiforme. Okay, yes, in the drugs it is NSAIDs, so like fixed drug eruptions, SJS, TEN. So in the erythema multiforme also NSAIDs will play a very important role. And in the connective tissue diseases, it is systemic lupus erythematosus which is having a very important role in the development of erythema multiforme. Okay. So now we will see what are the differences between target and targetoid lesions. So target and targetoid lesions, the conditions in which they are seen and the morphology of the lesions is different. So first we will see the morphology. In proper target lesions, we are going to see 3 zones. Central erythematous followed by pale zone followed by a peripheral most erythematous zone. So this is the erythematous zone, this is the pale zone, and this is the central erythematous zone. Whereas in targetoid lesions, so we have already seen discoid, disc-like. So targetoid is target-like. This target-like condition, targetoid lesions are going to have only 2 zones. Only 2 zones. There is no central palar zone here. So you can see central most part which is showing erythema, intense erythema followed by a peripheral rim of mild erythema. So only 2 zones are there and there is no central zone here. So these are called as targetoid lesions, and you should know the examples also. So in target lesions, erythema multiforme, erythema chronicum migrans, these are the examples. And targetoid lesions, they are seen in Stevens-Johnson syndrome and toxic epidermal necrolysis. So these are the classical lesions. Okay. So targetoid lesions also seen in sweet syndrome. So in sweet syndrome, it is basically a neutrophilic dermatosis where we will see erythematous plaques developing, and there will be pseudo vesicles which can develop. So it is not proper targetoid lesions. Yes, Dr. Kestrel Joe's targetoid lesions, pale area is absent. So these lesions which you are able to see, these are targetoid lesions. No central zone, that is no pale zone. Pale zone is absent. That is no edematous zone. No edematous or pale zone. Yes, you are correct. Okay. So that's it in this particular session, friends. So in the tomorrow's part, we will see in detail about the mainly sexually transmitted disease and a few important questions about hair. So one question was asked from the hair. So we will also see aju baju questions related to hair which were asked past in the JIPMER and also which could be potentially asked in the future also. So these STDs and pathology questions, whatever were asked, I am going to discuss in this tomorrow session. So to access this particular session of tomorrow, it is again going to be from 10 o'clock. So please download Unacademy, which is India's #1 learning platform. So download and follow me on Unacademy to get all the latest updates. And if you like this particular classes on Unacademy live classes, so you can always take up the subscription of Unacademy. And if you wish to take a subscription of both Prepladder and Unacademy both put together, you can take a like if your target is NEET PG 2022, let's say for example, you can opt for this iconic subscription which with a minimum of 12 months duration with the subscription fees, and you can use my referral code DRMSD, after which you will get additional discount. Okay, so thank you so much for all your patient listening, and we'll meet again in the tomorrow's session of the part 2 of the INI-CET November 2020 recall questions discussion. Okay, thank you so much for all your active participation and patient listening. Bye bye. As usual, as always, please follow SMS, social distancing, mask and sanitization, and as usual, happy learning.